Welcome. So, welcome to our session this morning on opioids in America. It's our continuing discussion at Medicine X on a topic that is very important to us. It's a conversation that we started last year at our conference. Several of our participants are here at the conference this year, and Frank Lee was part of our panel discussion last year. And we are continuing that discussion this year, but in a different format and with additional participants. So what we wanted to do this year was to have a conversation about opioids, but frame it in a way that Amy Edmondson probably suggested best, which was, if you remember the cartoon from her presentation where she had the executives all sat at the table and everyone was saying yes, but the cartoon bubbles said something else. This panel is about the cartoon bubbles. We want to talk about misconceptions and misperceptions. And we want to uncover really the truth, the true conversations about opioids, so we can start to really get to the heart of what matters, and so that we can begin to design around some solutions. So what I asked our panelists to do today was to start by each giving a short introduction, and then 60 seconds. And I said I was going to be kind of strict on the 60-second rule. But to speak for 60 seconds on what they thought was the biggest misconception or misperception about opioids in America. So I want to just start by going down the line, by having each of our panelists introduce themselves briefly. I won't count your introduction as part of your 60 seconds, but then please, I want you to share with us what you think is the biggest misconception or misperception about opioids in America.
So my name is Joe Reif. I'm a left above knee amputee from a traumatic accident. I'm also a paramedic in Madison County, Kentucky, which is a mixture of urban and rural areas. For me, the biggest misperception, I think, is that the use of opiates identifying you as a drug seeker or as a drug addict. Opiates are used by everyone in every socioeconomic area for chronic pain. And the use of an opiate, and for me, like, I have to get so many hoops because of my job. Even though I would never take an opiate on duty, but after duty, I'm in so much pain from my amputation, I'm forced to use them. And it's really looked down upon in the medical community especially, that if you use opiates, then you're weak or you're a drug addict or you're a seeker. And so I think that's one of the biggest misperceptions.
All right.
My name's Heather Aspel, and I've been a chronic pain patient for about 20 years due to a systemic autoimmune disease. And I think that the biggest misconception about patients like me who use opioids is that they're just being thrown at us. Like Joe said, we could go through so many hoops to get our medications, and it often requires going to multiple pharmacies. I was speaking with Britt Johnson this morning, and she said I could share that she had to go spend 4 hours trying to pick up a prescription. So beyond simply getting a prescription from a doctor, it can be challenging to even find the medication. So it's not something that is being thrown at us like candy, as is sometimes portrayed in the media.
I am Ashley Elliott. I am a recovering addict. December 28th, 2012 is my clean date. I'm also a psychology major. For me, I think a lot of the misconceptions are that people that are addicted to opiates want to be or choose to be. Sometimes I believe that addicts are looked down upon, and they don't always want to use them. Like, I know for me, they don't want to use them. And the second part is when you are a recovering addict, finding a doctor who is willing to treat you as a human as opposed to an addict. That's the hardest part for me.
I'm Dr. Tom Klein. I was hatched here down the street at the medical center and have practiced family medicine for 44 years, specializing in long-term illness. The misconception that I believe is the biggest one is there is no data to support the fact there is an opioid epidemic. There is no data to support that lots of prescriptions have caused the problem. There's no data to show that high dose, long-term, or powerful medications have caused the problem. But these beliefs, and they are beliefs because they are not scientifically proven, led to the worst publication in the history of American medicine. And it was an attempt by CDC to limit the amount of pain medicine. There was no scientific basis for it. It was done based on opinion. This, within 12 months, caused a new crisis, an opioid refugee crisis, which you just heard a little bit about. 40% of respondents say the pharmacies are refusing to fill their prescriptions. It's very bad out there, and nobody is tracking it. There's about 6 million people, we estimate, who are currently being decreased in their medication or cut off. The stories are unbelievable. We now have 20 documented cases of people who were cut off who have killed themselves. In the words of Forrest Tennant, who is our senior pain management doctor, this is inhumane.
So my name is Frank Lee. I'm a pain physician practicing in the Washington, D.C. area, and I'm also adjunct professor, and I teach at Johns Hopkins Pain Clinic. The biggest misconception, if we could go back in time to the 1990s, the biggest misconception then was that we're adequately treating pain. Because we clearly weren't. There was ample data, especially amongst cancer patients, that show that we really weren't doing a very good job. We liberalized the use of opioids, and then the pharmaceutical companies basically marketed towards primary care physicians, all forms of physicians, and said we should give opioids to everybody and treat this new fifth vital sign. You fast forward to today, about 25 years later, and the biggest misconception today is still the idea that we're adequately treating pain. There's still a lot of data, research papers that show that we're doing a terrible job, not only in cancer patients, but in post-surgical patients, in lots of different populations, including chronic pain patients, that what we're doing right now isn't a very good form of treatment. And I think now is the time to reevaluate the paradigm, and I don't believe more guidelines is necessarily the answer. I think we do have to work together, providers and patients, to come together and re-examine this pain treatment paradigm.
Thank you. My name is Keith Humphreys. I'm a professor of psychiatry here at the university, and I'd say the biggest misconception is that the U.S. is normal in how it handles prescription opioids. So let's compare ourselves to another country, Japan. For example, older population than us, you would think more aches and pains, universal access to health care, some more opportunities to prescribe. So consider the amount of standard daily doses of opioids consumed in Japan, and then double it. And then double it again, and then double it again, and then double it again, and then double it a fifth time. That would make Japan number 2 in the world behind the United States. Every other developed country does at least as good or as poor a job as we do managing pain while not using opioids at anywhere near the same level. So we're number 1, but not in a good way, and we need to learn how other countries handle these medications.
Great. Certainly, I think these are not common things we hear in the everyday media. They're, I think, accurately described as misconceptions and misperceptions because we don't hear them often. I think some in the audience might have some strong reactions to some of the things that we've heard. Some on the panel might have had some strong reactions to what we've heard. I want to give a chance for each of the panelists now to, if you want, to comment for up to a minute on what you've heard each of your panelists say. And then I want to open it up to the town hall with the help of Nick Dawson, who's ready on standby to come out and help us with the town hall moderation. But first, I want to go back down the line for a moment and give each of our panelists a chance to comment on what you've heard so far and respond to it.
So going off what Dr. Klein said about the fifth vital sign and pain being measured, I think a lot of education needs to be done in that area because we're not teaching patients about acceptable pain levels. We're teaching patients, they hear 0 to 10, so they think 0 is where they're supposed to be. I think the implementation of pain as a vital sign has increased the use of opiates because that coupled with the surveys and things that different hospitals have to fill out for their patient satisfaction, they were going to throw pain meds at people to try to get them happy so they fill out their survey properly, so that it looks better on them. But we're not teaching patients that it's okay to be in pain. Like right now sitting here, I'm at a 4. That's my normal pain level. I'm wearing my prosthesis, I'm at a 4. When I get to an 8 or a 9, that's when I need my pain medication. And we're not educating patients on a daily basis that this is where you need to be. This is what should be acceptable for you.
Yeah, kind of, I guess, piggybacking off of that, I think that the crisis that Dr. Klein referred to of patients being unable to pick up their prescriptions is an aspect that really needs to be addressed. It isn't talked about enough because I get refused from pharmacies regularly, and it requires me to spend hours trying to pick up my prescriptions, which only increases my pain and results in me, potentially needing to take more opiates than I would have needed to otherwise. So we need to find a way to address that refugee situation.
Going off of what Tom said, I know my father is in pain management, and he's currently going through all of this as well. And sometimes I get that feeling, that guilty feeling of like the issue with opiates that cause overdoses or death or the addictions has an impact on the people in the background, people that don't have issues with addiction or opiates or stuff like that. Because I know my father weekly, he gets his prescription weekly, has to go get those medicines filled. And so I feel like it's not fair, having been in pain management for 12 years, and now all of a sudden with all of these guidelines, everything changes and makes it harder.
Punish the many for the few.
Yeah.
People who have opiate addiction have been lepers for 100 years. And now another 9 million people are lepers because they take pain medicine. One of the criticisms is that we prescribe too much pain medicine. I have had a hard time finding out how that's actually related using database stuff. But one interesting fact, we prescribe twice as many milligrams of pain medicine than do they prescribe in the UK. So what do you think the two addiction rates are? They're both the same.
What I sense from everybody here is that there's a lot of angst and frustration from the patient side, from the provider side. On one hand, patients want more access, and some providers want more access so that we can help more patients. I think there's good intent on both sides. we want to help patients, and patients want to be helped, and there to be more openness and access to it. But one thing we do have to keep in mind is that overdoses, and you can speak about this as well. You see overdoses every single day, sometimes multiple overdoses every single day. And there's ample data nationally that shows that with the rise in liberal use of opioids, this has become a really deadly force in America. But that shouldn't stop us from being able to treat patients who have legitimate pain and chronic pain. How do we balance that? I think we have to start talking and start taking more information and advice from patients and be able to communicate better. We shouldn't just have an expert panel made up of a lot of academic physicians who don't prescribe pain medications to patients and have them decide how the rest of the private world and community hospitals should, prescribe and treat patients. We shouldn't leave patients completely out of the pictures and say, look, we got this. We're going to handle and we're going to tell you how to do all this and take medications and come in every week, every 2 weeks, every month to get the medications and sometimes be refused by pharmacies just because you looked the wrong way or you came on a Friday night to pick up your prescription. And I think, this is a good start to kind of let it all out and talk about how can we help each other.
So a lot of good things said, and I wish there was more time for everyone to talk more. Let's say, first off, if you want to know, everyone should know how much prescribing is in different countries. It's public information. You can get it from the United Nations. It's very well tracked. And the U.S. we do dwarf any other developed nation by a very large factor. So we overprescribe. And at the same time, there are people who absolutely need these medications. And by the way, I worked in hospice for a decade. And they don't get them. So they're also underprescribed. So the solution to this, which I'll quote my friend Sean Mackey, is shouldn't be pro-opioid or negative opioid. We should be pro-patient. And sometimes that means providing more than we have, and other times that means providing less.
Great start, I think, to hopefully some more insightful discussion to continue. What I want to do right now is to invite out Nick Dawson, Executive Director of the Sibley Innovation Center. And Nick, can you help us get things started with some audience participation and discussion?
I'm really looking forward to this. Some maybe remember, if you were here at the very end of last year on Sunday, we did a group brainstorm. And it was such an incredible opportunity to pull the wisdom from the MedX community into the conversation. And that's what we want to try to do here again today. And I want to start by recognizing that this is hard work. Coming up with ideas and potential positive solutions to topics as important and challenging as this is hard work. And we've done some of this, the most important part already, and that's the learning and the listening. And I think you're absolutely right. If we had time, we could do this for hours and still just be scratching the surface. But we started to listen and hear some stories, and I want you to keep those in mind, as well as your own experiences as we go through this together. And we're going to use that with that how might we phrase that we started yesterday and to think about some of these things in a creative way. And so some of the questions that we have for you today to think about, including some that we're going to start with in just a minute, may sound a little bit whimsical compared to the weight of this conversation, but part of that is so that we can unlock a little bit of fluidity and hopefulness in our thinking. There's not a lot of things around here we have rules for, but there are a few rules of the road here, and I've got some help from Michael Sears, who's going to help me navigate this and collect our ideas. But I wanted to share a couple of those things. So first of all, the only tools we need to do what we're about to do are the things you brought with you in the room today. It's your wonderful minds. We're going to tap those now, and it's your ability to empathize with the points of view we've already heard this morning. And then I'm going to give you just a couple quick rules on that. These are really easy. We're going to go for quantity here, and that means that all of us have experiences in the room, and we could each tell them and take a lot of time to listen to each other. But in this mode, we want to go really quickly and get as many ideas on the board as we can. And that means we're all going to have to be pretty efficient. So I'm going to jump in the audience here in a few seconds. I'm going to come be with you. I hope you'll put your thinking caps on and raise your hand and tell me when you've got an idea you want to share. But I'm going to ask you to share it really quickly, and I'm going to ask it to be an idea, not an experience or a story of yours. And then we're going to defer judgment. So if somebody says something and you think that is so out there and it wouldn't work, just remember that's their gift to the room, and honor it. And it might also help you think of the thing that you want to add to that, so you can build on those ideas. I want you to be bold and think of really wild ideas, even if they feel completely impractical. Go really out there, because it might encourage somebody else to think of the wild idea in their mind. And most importantly, be kind. This is an important topic, but it's a hard topic, and I want to honor the expertise we have in the room, as well as all these experiences. So the first brainstorming prompt we've got is, how might we make discussing opioids feel as safe and as comfortable as discussing what we had for breakfast? We've already heard that this is a hard topic to think about. I'm going to come and be with you, but I want you to think about really creative ideas. And this is the part where we're going to amp up the energy a little bit. I see a hand back here, and I'm going to come do my Phil Donahue impression.
I have a lot I could say about this, but this question of the role of opioids and how are we going to discuss it comes from my background in metabolism. I've been looking at opioids and their use for the last 40 years, working out mechanisms by which they can molecularly mediate their action. When you come to understand how they work, they then make much more sense. And it goes back to, they were used to treat diabetes before insulin was discovered. The role of opioids is in metabolism and how it organizes behavior.
I've got to play the role of...
Yeah,
I got the idea.
I got the idea. So the idea, the idea is, we need to take an understanding of opioids from a metabolic perspective and their mechanisms of action, so that we can appropriately apply them to the clinical thing. And I thought Britt Johnson last year summarized it when she said, "Study me."
I like it. I like that idea of taking it to the metabolic level. I saw a hand over here.
It's a good thing he's a marathon runner.
Good. My idea is that instead of us doing just a pain scale 0 to 10, let's ask, how does it impact you? And what is your goal in doing this pain management? Because then we have truly understood what they want.
Fantastic. I love that idea of thinking differently about the pain scale and the goal. Sean?
Yeah, I use a 3 bears method, a little bit, medium or horrid.
Well, I like that.
Shift conversations on palliative care from end of life to quality of life, and change that stigma.
That's wonderful.
Yeah.
That's fantastic. But a couple more on this. I'm going to come back there. I didn't
Well,
think this
at
was
least
going to be my
For
workout.
pain skills, I normally ask what their 10 is to try to find out where they're at.
So
as well.
last night, before I put my daughter to bed, I put a My Little Pony circle Band-Aid on her owie from school. I think it's really important to simplify the conversation, and also potentially involve all types of people who encounter pain, so that you get a shared perspective. I learned so much from my daughter, and she's 2.5. So involve kids.
Yeah, a lot of times we make things really complicated, and that idea of simplifying it could go a long way.
I would say kill the term alternative pain management. You know, Dr. Chu's invitation for me to come here is pain management. I go skiing for pain management. There's just pain. There's no such thing as an alternative, idea or management or, med. It's all pain management.
I love that concept of honoring what each person defines as their own pain management. I'm going to switch us to the next question. So if you have an idea, it still may be relevant. Michael, if you could give us the next prompt. So the next one we're going to think about, we're going to keep using this how might we frame. So how might we remove the stigma surrounding opioid use and prescription? And you had your hand up, so I'm coming to you first.
Thinking of patients as people and not just numbers. I'm not a data set. I'm not a point on a graph. I'm a person. And also understanding that pain is subjective, right? So as a chronic pain patient, I experience pain differently than someone who breaks their leg and has never been in chronic pain before.
That sounds very similar to your comment, Joe.
Yeah.
How might we actually train all healthcare providers? Because I resonate with the fact that you guys have to wait 4 hours and hunt down your opioids, because I teach my students that they better not judge or I'm going to whack them across the head.
God bless you.
Thank you.
But it's a mindset that because we are the easiest target for the DEA,
Right.
that it's also a change law enforcement's perspective and have them be at the table.
Absolutely.
It's powerful. And I'd invite our panelists, too, as you're thinking about these same brainstorming questions, this one of removing stigma on use and prescribing, if you have any thoughts.
Yeah, the DEA is a big part of our problem.
Yeah.
It really is.
Definitely.
You know, physicians are worried they're going to lose their careers, you know, with a raid from the DEA.
When we write prescriptions as clinicians, we often, especially if they're quote unquote as needed prescriptions, we write what they're for. And instead of writing that a given opioid is for pain, we might consider writing what activity it's intended to help the patient accomplish.
On that, my physician, the way that my prescription is wrote is for, for me to take them after my shift because of leg pain. It's an identifiable, quantified issue.
How might we find the cross-section? As a sober addict and alcoholic, I find the people who are pain management patients and also sober are some of the most important, I'm biased, but the most important people to talk to because they can actually see both sides of the fence. And I feel like they're often disregarded because they're sober.
So I want to amp up the encouragement of the really bold, wild ideas. And remember that part of that is letting go of things we think might even be legal or practical. And sometimes we say even if it feels immoral, because it might change some thinking in the room. And I heard this discussion about prescription and the law enforcement. But what if we made opioids completely legal? What if we took away any law governing them?
Amsterdam method.
Pardon?
The Amsterdam method.
Maybe.
That's a
I saw some
biggie.
hands.
The prompt that we had for this, the first thing that came to my mind was the two words that is our sound bit today, opioid crisis, almost creates some sort of a stigma.
Yes.
So changing the sound bite.
Right. The media is a big contributor, I think, to a lot of these misconceptions.
Which is actually why I did not call this panel opioid crisis. I called it opioids in America, and it was a town hall conversation.
There's actually one more word we need to get rid of that's inaccurate, and that's the word opioid.
Yeah.
Because opioids, if you look it up in the old Webster Dictionary, it says endorphins and fentanyl manufactured drugs. It's not even a correct term. And when you read the data, it's very confusing. The best word, believe it or not, is narcotic.
Yeah.
Because it covers all of them.
So going off Nick's, wild, how might we, the one I would think of is how might we differentiate between chronic pain or actual pain patient versus, abuser? And how might we, is psychological profile, whatever that may be, how might we differentiate between the two so we're not punishing the many for the few?
So I think I was responding to the one about stigma. So what if you had like a leaderboard and you could be having competitions or on a number of things, including I'm a real addict. I'm taking a lot of drugs. So like invert the idea, right? But there might be another leaderboard, which is days, pain-free or whatever the right metrics are, but make it almost social and a kind of friendly competition.
I love that, like almost gamifying it and taking, so the stigma goes from that to something you'd feel really positive about. Michael, let's flip to our next question. I'm not giving you much warning, am I? So our next how might we prompt here is how might we leverage patient and caregiver stories in policy making to create compassionate laws? I'm blown away by the stories we've heard today, and I'd love to hear some thoughts on how we can keep leveraging those in the way we think about policies.
How about we get politicians to listen?
Yes.
There you go.
So I'll start off with, there's a wild idea. Remember that scene from Clockwork Orange where they prop the guy's eye? We bring all the
I'm down for
MedX.
Mitch McConnell's my Senate guy. I'd be down for that real quick.
Guys, there is a power to advocacy on Capitol Hill. I've been doing it for 20 years on behalf of Alzheimer's families. There is nothing like seeing that sea of purple in the spring on Capitol Hill of Alzheimer's advocates. Why can't we do the same for this topic? Pick your color and have families descend on Capitol Hill and tell their stories. It is powerful. It works.
But on that note, there's a lot of people who are afraid to come out that they use opiates.
Yes.
There's such a stigma with it. Like for me to sit here as a paramedic and say that I do, I'm risking my career.
What if patients and caregivers could filibuster in Congress and take the floor?
So I'm an oncology nurse and also a chronic pain patient, and I cannot integrate those two aspects of my own life.
Mm-hmm.
So what I say is nothing for us without us. So no one should be making policies about opioids and pain management without involving the people who experience it day in and day out.
Yeah, I read nothing in the CDC guidelines about interviews with people in the addiction community.
So it's this question of involving patient and caregiver stories and policies.
Well, even what if we started at a more granular level? What if chronic pain sufferers and sober folks were at every hospital meeting about this? If you could literally not have a conversation about this if there were not someone in there who had experienced it.
It's a wonderful idea.
Yes.
Yeah, one of my most informative cases, I've now contacted Senator Heller's office to be able to make she takes large doses of morphine. So we now actually have a senator that is trying to make sure that she can get her a very unusual opioid dosing, which is life-saving for her, to get the politicians to recognize that there is an issue that has to do with these patients will teach us how medicine really works. We need to pay attention to the exceptions. And the politicians are ready to hear that.
I'm going to, my way over, I'm going to stop here.
Sit-ins and storytellings at pharmacies.
Oh, I love that idea. I'll be right back.
I've tried to get that going on my little tweet stream, and the problem is people are afraid they're going to get cut off.
Yes, absolutely.
You know, if they go out and, there's barely hanging on, maybe with one doctor who's given them half the appropriate dose, and they're really afraid.
Well, I think before we have a discussion about opioids, we need to have a discussion about how we as a culture deal with pain. Because on the one hand, there's this whole no pain, no gain ethos. There's a sense that, well, pain is just, it's what builds character and it's part of the American way to just, push through the pain. On the other hand, we're comfort junkies and everything, there's a sense that nothing should ever be uncomfortable and everything should just be smooth as silk. Like you were saying, like there's no appropriate level of pain. So I think we're very schizophrenic as a culture in terms of how we perceive and deal with pain as a phenomenon of life. And we have to have that discussion.
And I'm afraid doctors are pretty guilty. If you come in and say, I had so much pain, I can't stand it, they don't believe you. If you tell them you had shortness of breath and chest pain, oh, you do?
So true.
Well, a lot of docs want to use vital signs against chronic pain patients. So sitting here, my vital signs are going to be normal. I've adapted to this level of pain. So it's there's a lot of subjectivity there and a lot of bias there.
I'm from Canada, and I'm actually sitting here very confused by the conversation as to whether you're trying to increase, decrease, or stay the same in opioid use. So I'd use patient stories to clarify what the ask actually is of your politicians in this dialogue.
It's incredible. Michael, maybe you can help us tee up the next prompt. I'm loving this. I'm going to be the one to try to keep encouraging some of the really wild and crazy ideas. So what if just on this one, as Michael's switching us over, what if all of the policymakers, what if we wired them up with electrical shock and they had to experience pain? Or what if we dosed them all with opioids one day? I know that sounds almost silly and even maybe inhumane, but I want to encourage some really bold ideas because there's psychological safety in this room.
To
so
respond
I've got
to
a
the
couple
fellow
others.
from Canada, the politicians are practicing medicine.
Yeah.
Yeah.
Period. There's actually a federal law in this country that prohibits the federal government from any interference in the practice of medicine, which they're ignoring.
We could do, how about we let EMS providers be first line in teaching patients from overdoses. You know, give us literature to give out. I mean, I'm trying to push that at work.
I also think we need to involve more about addiction in the conversation, because there's just such a fear and around it that we're not talking about it. And maybe as we talk about addiction more and get the stories from people who are suffering from the disease of addiction, we'll better be able to eliminate some of the fear that we have around that issue.
That's a very good point. And addiction only occurs in a very small percentage of people. If you take 100 people coming back from Vietnam all hooked on IV heroin, guess how many were addicted out of 100?
So that's a nice transition. I wrote a couple other ones just based on the panel discussion that I thought we would maybe explore right now. One is, how might we see the humanity before the addiction?
Yeah.
That's a challenging one, especially with me. I'm dealing with, on some occasions, the same patient over and over and over again that I'm giving Narcan to. So on one side, you try to find out, you know, why are they doing this? Is it a socioeconomic reason? Is it a depression? Is it, you know, their pain medicine got cut off? And why are we doing this? So I think that, you know, how about we find the front line, the bottom line reason why this happened? Addiction isn't a disease. Addiction is a symptom of something else.
So let's brainstorm about this idea. How might we see the humanity before we see addiction?
We need to make pain management and addiction and this whole conversation intersectional, right? We know that people of color receive less pain medication than white people. We know that women receive less pain medication than men. So we're looking at the whole person, right? Looking at them as a person. So I'm a chronic pain patient, and my sister is a recovering addict. And looking at my sister as a person, looking at her addiction as not a flaw in her character, but just part of who she is and part of a larger picture. And I think that until we start looking at the whole person, until we're starting to make this whole thing intersectional, we're really not gonna get at the root of like what is. And addiction can be caused by anything also. You know, opioids make up a very small percentage of what people are addicted to in this country. Alcohol is completely legal, and yet that makes up the majority of what people are addicted to. So thinking about addiction as not, you know, connected to this one illegal substance, but as a bigger picture kind of thing.
Fantastic. Let's keep brainstorming with some of these rapid ideas. I'm coming back here.
Remind clinicians before they go into the clinical encounter of how their biases are likely to impact the stories that they hear from patients, in particular about their pain. So building on the comment there that this is a woman, you're less likely to believe she's in pain. This is a person of color, you're less likely to believe they're in pain. This is a recovering addict, you're less likely to believe their stories around that and how that might change than what they hear.
Like I'm sorry. I'm redheaded. It takes more pain medicine for me anyway, so I'm already behind the 8 ball.
Yeah, and I think it's similar to what was just said. Different patients show their pain differently. So just because someone's coming in, you know, limping and screaming doesn't mean that their pain is the same as or different than someone who's sitting there quietly. So I think clinicians need to get to know their patients and how they are showing their pain.
I think kind of going off what was set up here in the front, I'm a part of a 12-step program, and they say drugs are just a symptom of our disease, which I believe wholeheartedly. Finding my doctor, I had to go through a point where I had to sit down with her and tell her that I was still human. I recently had a fusion done on my neck from my C5 to my C7, and they were still looking at me as that addict, you know, as opposed to looking at the fact that, you know, I had pressure on my spinal cord or this, you know, that I was actually in pain. So I think doctors, that one question, you know, finding that compassion and being able to separate the addict from the human.
Because if that was a cancer patient that had been in remission, they're still not looking at you like a cancer patient. They turn to look at you as a patient after that.
Let's get a couple more ideas from the audience on seeing the humanity.
So it's worked with a lot of other diseases. I think we need to get prominent people and celebrities to tell their stories. What about the ANA and the AMA taking leadership roles and asking their members to go public with their experiences with addiction? We are often both clinicians and patients.
That'd be great to change public opinion.
A couple more ideas here.
So my wife is a pharmacist, and a lot of times when she actually gets the prescriptions coming in, it doesn't say what the prescription is for. It says, yes, about the drug, but it doesn't give any history behind it. What if we actually got the physicians and the pharmacists together, and I don't know if it's creating a new maybe job, but the process would be basically that the doctor and the pharmacy share the information so that you don't have to keep going to pharmacy after pharmacy and keep getting denied for hours and hours and hours.
That's why we need open records.
Very good idea. We're actually considering a special, sounds silly, certificate where you go to your doctor, or you go to your pain specialist, and they certify you as having this particular disease, and these are your ranges. And that'd be a way to share with pharmacists too.
Couple more ideas back here.
So I like to be very practical and immediate. I don't know if everybody is aware of the Patient-Centered Outcomes Research Institute and the funding that comes from that, but there's a letter of intent that is due October 2nd. How might we, the experts in the room, submit proposals through that mechanism to take some of these ideas and actually turn it into something that is patient-centered and patient-driven?
I love it. Emily, I saw your hand up, and I'm coming your way, and then I'm going to switch and see if we can get one more of our brainstorming prompts in.
My idea, so opioids are used as a tool to allow people with chronic pain to live their lives and do things. And so what if we start telling the stories of the functional benefits of effective pain management?
That's a good idea. We're actually working on that.
I mean, yeah, I'm a
That's a great
frontline
idea.
paramedic because of the ability to.
We've only got a few minutes left, and I'm really going to push like rapid cycle. When we're talking ideas, I want like really crisp, so we can see how many we can get. Because of where we are, we're sitting here in Silicon Valley. How would Apple and Google think about this? How would data companies and tech companies think about this?
Thanks. I mean, that was a great cue and segue to my question or suggestion. I was wondering, as an engineer, how we could potentially measure and quantify pain.
That's actually kind of in the works. They're doing some PET scans and some functional MRIs, and yeah, good point. We may be getting close.
But those are cost prohibitive is the issue.
Yeah, the cost is a lot, but so is the cost of making mistakes with people.
Got a couple more ideas here.
So pain comes as a symptom cluster, which means it's going to be associated with sleep, activity, and all other activities of daily living. So those are things that we are already able to track on different devices. How can we use then algorithms to identify a difference between a person who's in pain and not in pain, because those are measures that are actually possible to do.
Oh, I love that
If
idea.
you look at my Fitbit, like on my good days, I'm walking 5 or 6 miles. If I'm in pain, it'll be, lucky for 100 yards. So
And doctors have to decide whether they're going to believe their patient or not believe them.
That's it.
We'll try to get a couple more ideas here from the audience.
Grab a GoPro and try to keep up with me when I'm skiing, why I'm in pain or on pain meds, or why Heather's doing her art or Joe's at work. Actually film us while we're doing our life and trying to, participate in life and raise our own quality of life. And if you can keep up, good luck.
I like that. I could imagine a hashtag too, and there could be like this whole video series of doing really active things, or
Yeah, it'd be a good way to show the humanity of the issue.
So as a scientist and engineer, I feel we forget how to design with the community, and we end up designing for the community.
Yes.
So I think if we can build that in, so we are including everyone as we're designing, and we're designing together.
Was there one more? Were there any other?
How might Watson look at this problem?
My impression is that the opioids actually produce a sense of satisfaction, and I thought that Mick Jagger could have the theme song.
I like
I
it.
can't get no.
Yeah.
I love it.
We can sing it out in front of the pharmacy.
That's a wonderful note to end on. I love that this has become a tradition for us to incorporate this ideation session in some of our hardest discussions. I'm reminded, Dr. Tu, I'll turn it over to you here in just a second. I'm reminded that President Obama kept a sign on his desk that said, "Hard things are hard," and that we get to do this hard work in this room together feels very special. Thank you for engaging in that.
Thank you, Nick, for leading that really valuable town hall brainstorm. I think, there is no shortage of great ideas coming from our MEDEX community. And, I started out this conference asking for curiosity and asking us to be curious and to generate those types of ideas and to keep that desire of thinking outside of the box around these tough topics. And that's what we're doing this weekend. That's what I want us as a community to keep on doing after we leave. I think we made a start on that today. We're continuing the discussion around this topic. We're not going to come up with all the answers today, but what we're doing is showing as a community that we care about this issue. We're reducing the stigma around opioids by talking about it. When you talk about things, you reduce the stigma. We're raising the awareness, and we will continue the work and the conversation. So thank you for joining us for this. Thank you to all of our panelists for sharing their stories with us today. And let's keep talking. Thank you very much.
Thank you.
Thank you all.